Good morning and welcome back. So we're going to go right into it. Our first talk is reduction of prophylactic antibiotics for elective pediatric cholecystectomy, a QI initiative to promote antibiotic stewardship, and it's presented by Dr. Svetlanov.
Thank you. All right, thank you for the opportunity to present our work. We have no disclosures. Antibiotic stewardship has become an important area of focus due to the rise of microbial antibiotic resistance. However, data on the use of prophylactic antibiotics for elective cholecystectomy in the pediatric population is mixed. Antibiotic prophylaxis can reduce the incidence and morbidity of postoperative infections. However, it is not without risk and can lead to antimicrobial resistance, acute kidney injury, and infectious colitis. These complications can occur even after a single dose of antibiotics. Therefore, minimizing unnecessary antibiotic use is of the utmost importance. In 2017, a retrospective FIS database study of over 1,000 patients found significant variations in antibiotic prophylaxis for elective cholecystectomies and that the overall benefits did not outweigh the risks. In 2022, the Surgical Infection Society released guidelines recommending against antibiotic prophylaxis for elective low-risk cholecystectomy. In 2024, we implemented a QI initiative focusing on the need for antibiotic prophylaxis for elective cholecystectomy in children. Interestingly, since our QI project concluded, 2 retrospective studies have been published using NISQIP pediatric data that reported a higher incidence of surgical site infections in patients undergoing elective cholecystectomy who did not receive antibiotic prophylaxis. Our quality improvement initiative aimed to decrease prophylactic antibiotic use for elective cholecystectomy from 100% to less than 50% and to maintain that rate for 1 year. We defined our balancing measures as the incidence of surgical site infections and 30-day readmission rates. All patients undergoing elective laparoscopic or robotic cholecystectomies were included. Exclusion criteria included patients with acute cholecystitis or choledocholithiasis, those with an immunocompromised state, or those undergoing combined procedures. The project was initiated in January of 2024. Education was given to providers and modifications were made to the preoperative order set to ensure compliance. Patients meeting criteria in the year prior to the QI initiative comprised the pre-protocol group, whereas patients undergoing elective cholecystectomy after project initiation comprised the post-protocol group. Monthly P-charts were used to track compliance over time, and direct feedback was given for all episodes of noncompliance. 174 patients underwent minimally invasive cholecystectomy during the study period. 84 patients met the exclusion criteria as shown here. This left 40 patients in the pre-protocol group, all of whom received prophylactic antibiotics, and 50 in the post-protocol group. 3 post-protocol patients received preoperative antibiotics, a protocol violation, and 3 received intraoperative antibiotics at the surgeon's discretion due to bile spillage. There were no differences between the pre- and post-protocol groups in gender, ethnicity, insurance coverage, or median age at surgery. Prior to project initiation, all patients received antibiotic prophylaxis. After protocol implementation, only 3 of the next 16 patients received prophylactic antibiotics. Direct feedback was given to providers and further educational reminders were given to all staff. In the subsequent 9 months, no eligible patient received prophylactic antibiotics, resulting in a centerline shift as seen on this P-chart. There were no differences in operating time, intraoperative bile spillage, or postoperative length of stay between groups. All 8 patients with bile spillage in the pre-protocol group received preoperative antibiotics, while only 4 patients in the post-protocol group with bile spillage received antibiotics, 3 of which were given after spillage occurred. 1 patient in the pre-protocol group developed an SSI compared to 3 in the post-protocol group, which was not statistically significant. All SSIs were superficial and treated with antibiotics in an outpatient setting. Only 1 of the 3 post-protocol patients who developed an SSI had intraoperative bile spillage, and that patient had received 1 dose of postoperative antibiotics due to the bile spillage. Thus, of the 12 post-protocol patients with bile spillage, 9 did not receive any antibiotics and did not develop any infectious complications. Whereas 3 patients in the pre-protocol group required readmission, there were no readmissions in the post-protocol group. Limitations to our study include that this was a single-center quality improvement project and thus had a smaller patient cohort compared to national databases or through a multi-center collaboration. Only short-term data and complications were collected, although continued data collection is ongoing. Strengths of our study include its prospective data collection, enabling us to accurately track prophylactic antibiotic use and the severity and treatment of the SSIs. In addition, all eligible patients were included in our study, unlike many national databases that only analyze a small percentage of patients, leading to potential sampling bias. In conclusion, through this QI initiative, we decreased antibiotic prophylaxis for elective cholecystectomies from 100% to 0% in the last 9 months of the study without significantly impacting postoperative infectious complications. Adoption of evidence-based practices aimed at decreasing unnecessary antibiotic use may lead to decreased healthcare costs, a reduction in supply shortages, and a reduced antimicrobial resistance without increasing patient morbidity. Thank you. And I'd be happy to answer any questions.
We would like to go ahead and ask Dr. Monica Lopez to discuss this paper.
Thank you. Thank you for presenting such compelling quality improvement initiative to reduce surgical prophylaxis in this patient population. I think that's a really impressive way to kind of put together really important QI methodology to bring antimicrobial stewardship practices, in a way challenging our entrenched practices for this group of patients. However, as I'm sure you are aware of, recent publication of a very large-scale, multi-center NISQUIP-based study that demonstrated a almost, I think, 72% reduction in SSI with the use of surgical prophylaxis, a seemingly contradictory findings. So I'm just curious on your interpretation of those findings and what you think can be attributed to in terms of that differences. Is it a study cohort issue? Is it an outcome definition issue? And what would you propose we do to kind of resolve this conflicting evidence?
Thank you for that question. We did notice that during the making of the paper that these studies came out, and I think there's some significant differences. So one, I know in one of the 2 NISQUIP studies that came out, they included open cholecystectomies and those that had an intraoperative cholangiogram, which we know can have a higher incidence of surgical site infections. And those were patient populations that we did not include in this study, so I think our patient populations are a little bit different. One of the other things that I did mention briefly in the discussion part of this talk is that NISQUIP data and other large databases tend to just sample a small percentage of patients, and we included all of our patients in our study. So there may be a sampling bias in some of those large database studies. I do think that moving forward, in terms of either doing a multi-center QI project or continuing to look at our data at certain populations that may benefit from antibiotic prophylaxis versus those that don't, to better narrow and define our population, I think would be the next best step.
Great, thank you.
Thank you.
Our next presentation is entitled Preoperative Bowel Preparation Decreases Complications in Children Undergoing Colostomy Reversals, presented by Dr. Nofi, who's a general surgery resident at Norwell Health.
Thank you again for the introduction. My name is Colleen Nofi, and I'm a general surgery resident coming from Cohen Children's at Northwell, New York. And I'll be presenting on preoperative bowel preparations, decreasing complications in children undergoing colostomy reversals. We have no disclosures. Moderate quality evidence supports the use of mechanical and oral bowel preparations to decrease infectious complications in adults undergoing colorectal surgery. However, limited data exists regarding the efficacy in children. Therefore, the aim of this work was to determine the impact of bowel preparation on infectious complications after colostomy reversals in children. To investigate this, we utilized a multi-center retrospective review where data were included from 20 institutions from the Eastern Pediatric Surgical Network. Our inclusion criteria were children less than or equal to 2 years of age who underwent a colostomy reversal for an initial diagnosis of either anorectal malformation or Hirschsprung's disease. Ultimately, a total of 611 cases were included in our analysis, of which 52% were classified as having received no bowel preparation, and 48% were classified as having received a bowel preparation. Here you can see the practice patterns varied among the institutions, with green representing no bowel preparation and blue representing bowel preparation. Specifically, cases classified as having received a bowel preparation included patients prescribed either a clear liquid diet for 24 hours preoperatively, which included like a Pedialyte preparation, or patients receiving antibiotic or mechanical bowel prep. By this classification, 13% of the total cohort received clear liquid diet, and 36% received antibiotic or mechanical bowel prep. And again, here you can see the practice patterns varied among the institutions. Regarding our patient demographics, the mean age at the time of operation was 10 months. A majority of our patients were white males, and a majority of cases came from children undergoing colostomy reversals with an initial diagnosis of anorectal malformation, which comprised about 83% of the cohort compared to Hirschsprung disease. When analyzing our patient outcomes, we found the mean length of stay was 5.9 days, which did not differ between the bowel preparation and no bowel preparation groups. Regarding complications, the rates of surgical site infection, deep space infection, non-anastomotic perforation, enterocolitis, and the need for SSI wound opening were similar between groups. However, the bowel preparation group had a significantly lower rate of anastomotic leak, wound dehiscence, and return to the operating room. Interestingly, when we further subdivided the bowel preparation group to isolate out clear liquid diet only as a separate group, because this has not been studied in this way before, we found that only return to the operating room was higher in the no bowel preparation group. In contrast, the rate was similar between the patients who received clear liquid diet only and those who received an antibiotic or mechanical bowel prep. Finally, when we reclassified this group of patients who received only a clear liquid diet and considered them as no bowel preparation, and we compared those to patients who received an antibiotic or a mechanical bowel preparation, we found no significant differences in our outcomes, including complication rates, which became similar. To explore these factors in greater depth, we performed univariable and multivariable analyses to assess the impact of bowel preparation. When we included all forms of bowel preparation, including a clear liquid diet prep, an antibiotic, and a mechanical prep as a group, and compared those to patients who received no bowel preparation, we found a significant decrease in the associated rate of all major complications, as defined as surgical site infection, deep space infection, anastomotic leak, and wound dehiscence. However, when we adjusted for other patient and disease-related factors in a multivariable model, we found that this association was no longer significant. Moreover, when clear liquid diet was classified as no bowel preparation and compared to antibiotic or mechanical prep in a separate univariable analysis, we found no association with a decrease in all major complications. In conclusion, bowel preparation, defined as clear liquid diet, antibiotic, or mechanical prep, may decrease rates of infectious complications, including anastomotic leak, wound dehiscence, and return to the operating room. The impact of this clear liquid diet prep remains unclear, as it may be providing a similar protection to those that received an antibiotic or mechanical bowel prep in our study. And we think that institutions that are documenting this prescribed clear liquid diet prep may also have more standardized or protocolized periop processes, which could be influencing these reduced complication rates. So we propose that future prospective randomized studies are warranted to understand these specific bowel preparation strategies and try to optimize best practices in children. So I'd like to thank the EPSN group for contributing data and helping with this study, and I'm happy to take any questions.
Dr. Langer will be our discussant for this presentation.
Thank you. This study is really interesting because it kind of takes the pendulum, which, has swung over my career from, yeah, everybody needs a prep to nobody needs a prep. And now I think what you've done here is a good start. There's lots of patients, but there's so many covariables. And in your multivariate analysis, you sort of showed us that all of those covariables may affect the results. And so I don't even really know, my next colostomy closure, what I should be doing. And I'm retired, so that's going to be a long time from now. But I guess the take-home message for me is that the mechanical bowel preps and the antibiotics and all of those things don't seem to be any different from just clear fluids. And that by itself, if people just switch to that, if they're going to use the bowel prep, can save a huge amount of money and also, side effects and complications. So I look forward to hearing the results of the randomized trials that you're suggesting.
Thank you.
Hi, David Rothstein, Seattle. There's probably ask 5 surgeons, get 17 different answers on what's the best way to close a colostomy, but do you have any information about use of wound protectors, changing to clean instruments, loose closures, wicks, post-op antibiotics, and those kind of things that might affect your outcomes as well?
Yes, so we actually collected that information in the study. We tried to identify all factors that could be influencing infectious complications, and we all know that that's important. They did not differ between the bowel preparation groups and were not significantly associated in our model. Interestingly, most institutions were not performing purse-string closures, so it was interesting to even look at the practice differences between the institutions, but there were no associations in our study.
Thank you very much.
Thank you.
The next presentation is Feeling the Difference, Long-Term Sensory Outcomes Following the Minimally Invasive Repair of Pectus excavatum with and without intercostal nerve cryoablation, presented by Dr. Scott Eldridge, who's a research fellow and a surgical resident at Phoenix Children's.
Hey, good morning, and thank you all for the opportunity to be here today and present our research. We have the following disclosures. The use of intercostal nerve cryoablation during the minimally invasive repair of pectus excavatum has been well studied in the pediatric patient. It is time and time again shown to decrease pain, hospital length of stay, and opiate use both in and out of the hospital. However, a major lingering question of cryoablation, especially among the pediatric populations, is what is its long-term neurosensory outcomes? Critics of its use have quite astutely pointed out that there is a lack of long-term evidence to suggest its safety. Our group has previously studied chest wall sensation immediately following pectus repair. We found that at 3 years follow-up, just before the bars came out, approximately 50% of patients had complete return of chest wall sensation. Among those with lack of sensation, this was typically confined to 1 to 2 dermatomes. Additionally, we found that the sensation loss was typically medial to where the pectus bars exited the chest, as you can see in this dermatomal map here on the right. The darker the cells represent a higher proportion of patients with sensory loss. However, suggesting that the sensory loss may be secondary to the bars and impingement rather than the cryoablation. However, our studies failed to have a comparison group, and we really don't know what happens after the bars come out to sensation. With this background, we sought to determine the long-term sensory outcomes of patients undergoing pectus repair with and without cryoablation. We also sought to further define what the pectus bar does to sensation. To do this, we conducted a multi-center prospective study, including 5 pediatric hospitals in America. We included children that were less than the age of 21 who were undergoing pectus repair with and without cryoablation. We then conducted chest wall sensory exams prior to bar removal at 2 weeks post-op and 2 months post-op. Neurosensory tests were performed in a standardized fashion for all patients using cold stimulus, pinprick stimulus, and soft touch. We then stratified our patients based on cryoablation use during their index operation, and we compared between these groups full sensory recovery at different study intervals. We sought to quantify sensory loss using dermatomal maps, and then identify factors that were associated with sensory loss. In total, we enrolled 166 patients, of which 130 had cryoablation. We found no difference in their characteristics between these two cohorts. Importantly, we did find a higher proportion of patients had more than one pectus bar placed and paracostal suture use if they had cryoablation. This slide represents the proportion of patients with normal sensation just prior to the bars coming out. We found there was no difference between cryoablation and the non-cryoablation cohort in sensory return. These figures depict the dermatomal sensory maps to cold stimulus among patients with cryo and non-cryo. Again, to review, white means normal sensation, and the darker the cell, the higher proportion of patients with sensory loss in that distribution. As you can see, there is similarities between the two groups, with the majority of patients having sensory loss between T4 to T6, without a huge difference between the two. We then tried to determine which factors were associated with sensory loss and found that age, BMI, and Haller index or pectus severity were not associated with sensory loss. We also found that cryoablation, again, was not associated with this. However, we did find that having more than one pectus bar or the use of pericostal sutures were associated with persistent loss prior to bar removal. This suggests that impingement of the nerve by these bars may be associated with that sensory deficit. This graph represents the proportion of patients in each cohort with normal sensation to stimulus at different study intervals. As you can see, the blue line represents the cryo, the red line represents no cryo. As you can see, we found no statistically significant difference in sensory return at different study intervals. And I think really importantly to point out here, after the bars come out, we see that a majority of patients have return to sensation, regardless of cryoablation or not. When interpreting the results of this study, several limitations should be considered. There was a sample size discrepancy between our two cohorts. Many surgeons in our groups have moved to using cryoablation routinely, so it was difficult to recruit non-cryo patients. Second, our sensory exams are not a perfect science, and there may be some bias inherently introduced by them. And third, there was technical differences between our groups. To summarize, cryoablation from this study was not found to be associated with persistent sensory loss in our patients. The sensory loss seemed more likely to be due to nerve impingement caused by the bars or securement methods. And I think most importantly, after the bars come out, a majority of patients have return to sensation. Thank you, and I'm happy to answer questions.
We would like to invite Dr. Brown to be the discussant of this paper.
First, I'd like to congratulate the authors on this very important and well-orchestrated multi-institutional study on the long-term sensory outcomes after cryoablation. Nuss pectus repair is arguably the most painful procedure performed in our pediatric patients, and cryoablation has been a true game changer in post-op pain management. The major concern with cryo has been the potential long-term effects on sensory nerves with chronic chest wall numbness, or worse, chronic neuropathic pain. I know that we at Cincinnati Children's were slow adapters due to these concerns, but we too also had non-cryo patients with ES or epidural catheters with unexplained post-op numbness. This study clearly demonstrates that some degree of post-op chest wall numbness is common in both cryo and non-cryo patients, likely due to intercostal nerve impingement by the bars or by suture fixation around the bars, but most importantly, demonstrates that this numbness resolves by 2 months after bar removal, whether you do cryo or not. And this is great news for our patients and helps guide our pre-op counseling regarding post-op expectation and adds to the safety profile for cryo. Questions. Given the correlation of post-op numbness with the use of intercostal sutures, especially with cryo, do you foresee a decrease in this complication with the widespread use of connecting bars that do not require suture fixation? And also, with such a large cryo series with long-term follow-up after 3 to 4 years, did you identify any patients with not only numbness, but chronic or disabling neuropathic pain due to cryo? Again, many congratulations to the authors on this very insightful and important study.
Thank you so much, Dr. Brown. To address your first question, that is a very interesting point you bring up with the advancements of these bar bridges. I do potentially foresee less neurosensory sensory loss coming from bar impingement. So that you know, the future will tell us on that. And to answer your second question about long-term neurosensory pain, we did survey these patients with a neurosensory screening test called the SLANS. And we found that even with patients scoring positive, which was low, there was a low percentage of patients that scored positive, none were receiving gabapentinoids at that time, so making that probably clinically insignificant.
Song Kim from UCSF. It's been known that based on animal studies, the neuronal destruction occurs if the temperature used to freeze the nerve goes to minus 100 Celsius. So there is a reason for choosing minus 60 Celsius. So if minus 60 Celsius is used to freeze the nerve, it will not destroy the sheath around the axon, and theoretically the nerve should recover, which your study has shown.
Yeah, I think that's a great point that you bring up about the temperature of the nerves. As you pointed out, that most of these studies have all been performed in animals, and really no clinical studies have been shown to say that sensation does come back. I think the next step too, you know, besides temperature is length of duration of cryo. I know most people in the past have used a 2-minute duration, and I think people are starting to push the limit on that to see if you could go shorter to try to help sensation return if cryoablation at all is associated with that loss of sensation. So I know people are going down to 90 seconds or a minute, and I think future studies to determine whether or not the pain improvement associated with 1 minute versus 2 minute. Additionally, just that long-term outcome of sensation return may be different in the 1 minute versus 2. But yeah, I appreciate your question.
Next presentation is entitled Implementation Yield Success, Results of the Enhanced Recovery in Children Undergoing Surgery in Rich U.S. Randomized Control Trial, presented by Dr. Ravel from Lurie Children's.
Thank you for the opportunity to present our trial results. This work was funded by a variety of organizations, including the NIH. Enhanced recovery protocols for pediatric patients have really taken off in our field. If you look at PubMed, we see the exponential rise in publications in this space, and specifically, if we were to look at enhanced recovery protocols in gastrointestinal surgery, across the board, systematic reviews and meta-analyses now show that we can decrease our length of stay by 2 to 3 days, decrease our complications by about 1/3, and our readmission rates, which we look at as a balancing metric, remain unchanged. So we did this research because the literature to date that I just mentioned has been limited to single-center studies, and the extent and drivers of implementation remain understudied. To really fill this gap, we needed a large-scale, multi-center, randomized controlled trial, and thus the Enrich-US trial was born. Once again, it stands for Enhanced Recovery in Children Undergoing Surgery. This was a national prospective study across 18 children's hospitals over a 5-year time span. This included a focus on patients 10 to 18 years of age undergoing elective GI surgery, and our enhanced recovery protocol, which you all contributed through surveys, through APSA, as well as focus groups, had about 17 elements that we tailored to the pediatric population. Each of the hospitals created their own local implementation teams made of surgeons, anesthesiologists, nurses, and frontline care providers. These 18 hospitals were then randomized to one of 3 clusters of 6 hospitals. Cluster 1 had the shortest baseline data collection period, went through an intense 1-year-long learning collaborative session for coaching and enhanced recovery protocols, and then had the longest sustainability period. And if you look at Cluster 3, they had the longest baseline data collection period, and then the same 1-year implementation, followed by the shortest sustainability period. We looked at implementation measures in 2 different ways. First was just adherence with the 17 elements that span the perioperative care experience, and then secondly, a more methodologically rigorous qualitative assessment of frontline implementation through interviews and focus groups with the individual hospitals participating in this study. We looked at things like how they actually made sure that each patient was getting the enhanced recovery protocol. Did they have leadership and administrative support? Did they embed the protocol into their EMRs? We also looked at the traditional clinical outcomes that you all care about. Length of stay was our primary clinical outcome, and we looked at every other enhanced recovery type of secondary outcome you can think of, including patient-reported outcomes. And here's our results. We enrolled nearly 600 patients in this trial, making it one of the largest trials in our field of its type. About 75% of patients had IBD, as you would expect. These patients underwent real GI surgeries, ileocectomies, J-pouch creations, proctocolectomies, etc. When we look at our study results by the phase of implementation, what we're talking about is baseline versus implementation versus sustainability. We see a slow and steady increase in the number of enhanced recovery elements being implemented across the study phases. We did not detect a major change in length of stay. The length of stay for this patient population was about 4 days, agnostic of the phase of the study. And ultimately, we did identify a decrease in opioid utilization, both intra-hospital stay as well as at the time of discharge. Another way of looking at this same information is by the number of elements received at the patient level. So instead of a cluster level or a hospital level analysis, think of it as a patient level analysis. When we overlay the length of stay here, you see that as patients individually receive more elements of an enhanced recovery protocol, our length of stay decreases from about 4 to 5 days to 3 days. When we use our implementation driver score, once again, the qualitative assessment based off of 5 different domains, we're able to assign each hospital an overall driver score for successive implementation. And then we can break those driver scores down into terciles with low, moderate, and strong implementation. And that correlated nicely with the number of elements received, once again, at the patient level, and then also correlated with the hospital-specific length of stays. Another way of looking at this is with a cut point. So 13 was the median number of elements being implemented, so we can compare those patients with successful implementation, those receiving 13 or more elements of an enhanced recovery protocol, compared to those receiving less than 13 elements. And when we look at it from this perspective, those with better implementation had shorter length of stay by about a day. They had, in terms of prolonged length of stay, defined for this GI surgical population as greater than or equal to 7 days in the hospital. The number of patients in that prolonged cohort decreased from 25% to about 15% with implementation of an enhanced recovery protocol. We see our decrease in opioids, as I've already mentioned, and then our overall complication rate actually dropped from 26% to 16% with implementation. Our 30-day readmissions as a balancing metric remained stable, and our patient-reported outcomes were unchanged. So in conclusion, this is the first study to investigate both the clinical effectiveness and implementation of a pediatric enhanced recovery protocol. While we did not detect any significant changes by the study phase, overall opioid use, in terms of length of stay, overall opioid use did indeed decrease. And at the patient level, improved implementation was indeed associated with improved clinical outcomes. I want to take just an extra second to thank the 18 centers that participated in this trial from its inception. It's been nearly a decade of investment, funding, resubmissions for funding, COVID, and of course, we were the first national study funded by the NIH that had to use a single central IRB. So thank you all for your investment. I also want to thank the study team back at Northwestern and Lurie Children's. Could have done this without a tremendous amount of sweat equity over the past many years. So once again, thanks, and open to take any questions.
Sharif Emil, Montreal. Thank you, Mehul, for leading this really, really important work. I know it's hard to present so many results in a few minutes, but I was struck by one sentence you had that patient-reported outcomes did not change. because one of the themes, as we discussed yesterday, is a child's recovery is a family's recovery. So can you just tell us a little bit more about what those patient-reported outcomes are and maybe some perspective about why they did not improve with the ERAS protocols?
Yeah, thanks, Sharif. We embedded some pretty rigorous questionnaires based off of the PROMISE questionnaires for patient-reported outcomes, both for disability days and pain as well as quality of life overall. I just presented the quality of life data here, and we're still digging into a lot of the more nuanced data as it relates to days away from school or work or whatnot. And I think that as we glean through that literature and data a little bit more, we might actually have more of a story to tell.
I just want to rise to say that having the privilege of being older and having watched APSA develop and try to do this centrally through APSA, or as this has now evolved through regional and through other special hospital consortia, this is a special presentation. The work, the collaboration, the association, and the outcomes that you presented are very, very special. This is an example of the kind of outcomes vis-a-vis discovery that we can really, really profit from in addressing our mission and constant quality improvement. So I really, really congratulate you, and I hope that we can continue to get the attention of the NIH to support this, or foundations that understand how important this is and what impact it will have on children's lives. So thank you, thank you, thank you.
Thank you, Dr. Tree.
The next presentation is work relative value units in the association with operative time and surgical complexity, a pediatric NSQIP analysis presented by Dr. Katz, who is a resident at Mount Sinai.
Thank you. It's this one. Okay. Thank you. So, work relative value units, love or hate them, is how surgeons in America get paid for the most part. So let's talk about it. Each surgical procedure is assigned a CPT code, which is then assigned a work RVU. These RVUs are then adjusted, given an adjustment factor, and correspond to physician payments. So how are these work RVUs determined? They are recommended to CMS by a committee of physicians and are meant to represent time, physical and mental effort, physiological stress, judgment, technical skill required for the procedure. But these are big asks and pretty abstract. We can simplify things slightly by splitting the components down into time and case complexity. But still, how good of a job do work RVUs actually do? And how can we measure this in a concrete and numerical manner? This is what we aim to understand with our study. To do this, we utilize the pediatric ACS NSQIP database. Starting with the year 2022, we sorted CPT codes by frequency and then selected the codes that individually accounted for at least 0.1% of the database. We then obtained all procedures with these CPT codes from 2018 to 2022. We collected operative times as well as outcome measures such as complications, which we use as a proxy for case complexity. For each procedure, we calculated median operative time, work RVU per hour, and rates of major and minor complication. We then used linear regression analysis to understand the relationships between these variables. A note about complications. We chose to divide complications into major and minor because we hypothesized that these complications would not contribute equally to case complexity. Using the guidance of previous studies, major complications were defined as those that cause significant deviation from the operative course or outcome for the procedure, while minor complications were judged to have more minimal effect. And some examples are listed here. Now moving on to our results. In total, more than 500,000 procedures met inclusion criteria. They represented 181 CPT codes and together accounted for just over 84% of the data set. I'm sorry, these slides are a little bit old. We first plotted the median operative time against work RVU. Here, we can see that there is a modest association demonstrating that work RVU is positively correlated with median operative time. In other words, longer surgical procedures are being compensated more than shorter ones. But to what extent? To answer this question, we next looked at the relationship between median operative time and work RVU per hour. We found that for each additional hour of operative time, there was an associated 2.16 decrease in work RVU per hour, or 0.36 decrease per 10 minutes. This negative association suggests that for a longer time spent operating, the return on investment is less. After addressing this time component of work RVUs, we then moved on to tackle the more difficult question of case complexity, again using complication rate as a proxy. Here, we see that both major and minor complications are correlated with work RVUs, suggesting that overall, work RVUs are positively associated with case complexity. Lastly, we plotted the incidence of major and minor complications against work RVU per hour. When doing this, though, we realized that the association we previously saw between work RVUs and complications lost its statistical significance. This suggests that surgeons are not being adequately compensated for the increased stress and effort when performing lengthy procedures that are also complex. So in conclusion, using the pediatric NISQIP database, we found that work RVUs are positively correlated with operative time, but also that there are decreasing monetary returns per hour for longer surgical procedures. We also saw that complication rate is associated with work RVUs, but that this is largely explained by the increased operative time of these procedures. There does not seem to be additional work RVU-based increases for greater case complexity. Together, this suggests that pediatric surgeons are not being compensated adequately for the increased stress and effort that they experience when performing lengthy and complex surgical procedures, and that physician reimbursement for pediatric surgery may favor shorter and less complex procedures. There are plenty of future avenues and limitations to this study, but I want to expend the last few minutes focusing on the bigger picture. Do payments for pediatric surgery procedures need to be updated? And if so, how can we work towards doing this? I think the simple answer to the first question is probably yes. The second question is more complex and honestly a little politically charged. But I believe that armed with this data, there are many levels that this work can start to happen on. And I do think that it is important in the long term for pediatric surgery as a field to dedicate substantial efforts to advocacy and legislation because reimbursement for procedures ultimately does impact patient care in the long term. Thank you, and I'm happy to take any questions.
Hi, Weiss Hartford, and I'm the APSA RUC advisor, so I know a very small amount about this. And APSA does work on this through our practice committee, and I encourage anybody who's interested to change workshops tomorrow and come at 9 o'clock. And Duncan Phillips and I will be talking a little bit more about this. But, so there's been lots of criticisms of the whole RVU system through the years, including some that have been very significant out of the RAND Corporation. And the AMA, who runs the RUC system, has addressed these. And everybody acknowledges it's not a perfect system. And I've certainly seen that at RUC meetings. How would you suggest making a major change? Because one of our problems in pediatric surgery, while we have some pediatric-specific codes, we also go along with the general surgeons on many things. And what a lot of folks don't understand is the RVU is really given across the board to all specialties at the 25th percentile based on a survey that's done of participating physicians in a particular specialty who are going to get surveyed. As an aside, I would encourage everybody to participate in any surveys that you get about this topic. So again, that's the question. How would you change the system?
Yeah, I think that's a really great question, and obviously it takes a lot of really smart people working together, and thank you guys for doing this hard work. I think that one of the important things we can do is start to incorporate not only work RVUs as a measure for compensation, but incorporating more things. So that it's not just one value that's dedicating what people are being reimbursed for. So that could include things from value-based compensation to structuring the payment model in a slightly different way in order to have more reimbursement for things like complex care and other things that physicians do on a day-to-day.
Justin Lee from Phoenix. So I wonder if we're not a big enough society to leverage this politically. Do we need to work with our, ACS colleagues? And number two is this a sensitive time to ask for increase? I mean, I think, like, as a very highly compensated society and a subspecialty compared to our colleagues, like, do we really want to go in this direction, this publicly and politically?
Yeah, I think that's also a good question. I do think now is a time where a lot of, not just APSA, but other organizations that have a lot of physician support, kind of all physicians in general, can use this time to band together and kind of advocate wholly for not decreasing the Medicaid budget and things like that. But I do think that in the future, as we start to adapt how payments work, we can voice our opinions as different societies and also work with others in order to make sure that all physicians are being paid and reimbursed adequately.
Can I make one additional comment? We do work
very short, please.
Very closely with the ACS about all these issues.
Great. Thank you very much.
Thank you.
Our next presentation is entitled Improved Mortality in Gastroschisis Patients After Implementation of a Standardized Management Bundle in Central Malawi, a Single Center Follow-Up at 4 years, presented by Dr. Lua from Tulane.
Thank you so much for that introduction, and thank you for letting me present today. I think this is actually the wrong slide deck.
I'm so sorry. Looks like we have the wrong slide deck.
Yes. It's my slide deck, but it's not the most up-to-date version. But it's okay. Yeah, I'll present. All right, apologize for that. It is my slide deck, but it's not the most up-to-date version. But I shall continue. Thank you again for letting me present. This study was presented by the NIH, Fogarty. And the global burden of congenital study is the 5th leading cause of death in children under 5. And 97% of it is in LMICs. Gastroschisis is a major disparity in LMICs, and the mortality rate is 90 times higher in lower income country than higher income country. And the barriers to neonatal surgical care in sub-Saharan Africa include delayed presentation, limited access to surgery and ICU, challenges in infection control, and flu resuscitation and nutrition. So in 2019, Dr. Wright has implemented a care bundle that included pre-hospital and in-hospital care packages. And she has done a lot of work with the district hospital and as well as educating the in-hospital staff on this basic care of a gastroschisis bundle. And so this study was conducted in one of the 4 tertiary referral hospitals in Malawi that is serving a population of 7.5 million people. The pediatric surgical service here was established in 2016. This study included all neonates admitted for gastroschisis between July 2023 and June 2024. This data is compared to the cohort immediately after the care bundle was implemented. The primary outcome is mortality over time, and the secondary outcome are the predictors of mortality and survival trends. We recruited a total of 99 patients. Half of them were female, 32% were under 2 kilograms, and majority were premature. 93% of our patients arrived on day 1 of life. The survival rate tripled from 2019 to 2023, and the referral rate also doubled during that time. When we look at the characteristic of those who died versus those who survived in the 2023 cohort, the female and those who weighed under 2 kilograms have significant higher chance of death. Prematurity also trended towards higher mortality rate, but this was not statistically significant. On multivariate regression, the only significant predictor was weight under 2 kilograms. When looking at the survival curve against the hospital length of stay, it shows that the majority of our death occurred in the first 10 days of life. Here's a graphical representation of the gastroenteropathia care at KCH over time. When the pediatric service was first established, the mortality was nearly 100%. It improved to 90% after the care bundle was implemented immediately. And between 2020 and 2024, we established a pediatric surgery residency program there, hired a dedicated neonatal surgical nurse, had more availability of our second-line antibiotics. And our major takeaway from this follow-up study is that neonates who were under 2 kilograms have 4.6 times higher odds of dying. And most deaths occurred early and presumably from respiratory distress and sepsis. This is in contrary to the common belief that lack of TPN in low-income setting is a primary driver of death for gastroschisis patients. Some of our major barriers include infection due to reusing silos and lack of blood cultures for targeted antibiotic treatment. Inadequate resuscitation, including the lack of ventilator for neonates at our institution, as well as staffing shortage, because our nursing ratio often exceeds 20-1 on most of the days, and we have minimum overnight monitoring. And we're hoping by improving these barriers, we'll further improve the mortality of neonates with gastroschisis in our institution, and perhaps also other low-resource settings. Here are my references, and thank you again for letting me present this study.
So the next talk is cost effectiveness of metabolic and bariatric surgery in adolescents, a 10-year analysis, presented by Dr. Rode, pediatric surgery fellow at Laureate Children's.
All right, good morning, and thank you for the opportunity to present our work. We have no disclosures, and our funding is provided by the NIH. The CDC estimates that 1 in 5 children are affected by obesity in the United States at an annual medical cost of $1.3 billion. First-line treatments of obesity, including lifestyle modification and medication management, often lack long-term effectiveness, particularly in adolescents with severe obesity. However, among patients with suboptimal response to first-line treatments, metabolic and bariatric surgery has been associated with substantial long-term weight loss and improvement in obesity-related comorbidities in adolescents with severe obesity, with recent 10-year outcomes data demonstrating an average decrease in BMI of 20% for both gastric bypass and sleeve gastrectomy, as well as an average remission rate of around 55% for comorbid conditions. However, despite these promising clinical outcomes, there's limited data to know if these long-term benefits are worth the cost of surgery in adolescents. Therefore, the aim of our study was to evaluate the 10-year cost effectiveness of metabolic and bariatric surgery compared to non-surgical management of severe obesity in adolescents. We employed a patient-level health state transition model over a 10-year time horizon with 1-month cycle length. All participants started at an age of 17 with a BMI of 52, and 75% were female. We looked at changes in health states following one of 3 interventions: gastric bypass, vertical sleeve gastrectomy, and no surgery. This slide depicts a simplified schematic of our model. We used a computer-based simulated trial to determine cost outcomes in 300,000 hypothetical adolescents over 10 years. We start with a base case adolescent patient with obesity, with or without diabetes, depending on prevalence data derived from our clinical data sources. Then the adolescent undergoes one of 3 interventions with a total of 100,000 simulated patients per intervention. The patient then experiences health state transitions, including changes in BMI, and occurrence of surgical complications, diabetes remission, or micronutrient deficiencies, and accrues costs associated with these health state transitions, updated every month. We obtained clinical data from 2 sources. For our surgical cohort, we used the Teen Lab study, which was a prospective, multi-center, observational cohort study of adolescents who underwent metabolic and bariatric surgery with participant data available up to 10 years postoperatively. For our non-surgical cohort, we used the PWM program, which was a prospective, single-center, observational cohort study of adolescents who received nutritional counseling, as well as participated in group exercise sessions and behavioral intervention therapy with participant data available up to 7.3 years. For our health state transition cost variables, all participants accrued annual total direct healthcare costs based on age, sex, diabetes status, and BMI. And surgical participants accrued additional costs from the direct costs associated with surgery, early and late postoperative complications, and the long-term monitoring and management of micronutrient deficiencies. All costs were adjusted to 2022 US dollars. The primary outcome variables for our study were threefold. First, total costs. Second, quality adjusted life years, or QALYs, which is a period of time multiplied by a quality of life value, which is based on the participant's BMI and surgical complications and diabetes status when applicable. And third, and most importantly, incremental cost effectiveness ratios, or ICERs, which in basic terms is the number that determines if you get enough bang for your buck, where the buck is the incremental cost associated with one intervention over another, or the delta cost, and the bang is the additional quality of life gained for that cost, or the delta QALY. Our cost effectiveness determination was set at a willingness to pay threshold of $100,000 per QALY, which is most commonly used in cost effectiveness models in the United States. In terms of our results, no surgery was the least costly at $41,000 compared to sleeve gastrectomy at $72,000 and gastric bypass at $80,000. However, no surgery also provided the lowest QALYs in relation to surgery at 6.1 compared to essentially 6.9 for either surgery type. In terms of ICERs, the incremental cost effectiveness of sleeve gastrectomy compared to no surgery was $41,000 per QALY, and therefore cost effective at our willingness to pay threshold of $100,000. However, the incremental cost effectiveness of gastric bypass compared to sleeve gastrectomy was over $500,000 per QALY gained, and therefore not cost effective. However, in a scenario where sleeve gastrectomy is unavailable, or more likely contraindicated in a particular patient, the incremental cost effectiveness of gastric bypass compared to no surgery was $50,000, and therefore cost effective at our willingness to pay threshold. As with all models, ours is not perfect, mainly due to 3 factors. Our study's generalizability is limited in that we use 2 non-matched cohorts. We did not model indirect costs such as lost wages to the patient or caregiver. And finally, some model inputs were derived from adult literature, namely late complication rates and quality of life with diabetes, due to the absence of long-term adolescent-specific data in these areas. In conclusion, while the choice of surgery is highly individualized, from a long-term cost-effectiveness perspective, our model demonstrated that sleeve gastrectomy is the cost-effective strategy for adolescents with severe obesity over a 10-year time horizon. Thank you.
Our next presentation is entitled Multicenter Pediatric Surgery Qualitative Collaborative, NISQUIP Pilot Study, Pediatric Colorectal Surgery Bundle Utilization, presented by Dr. Brearley from Phoenix Children's.
Thank you to the program committee for allowing us to present our work today. We have nothing to disclose. Care bundles are groups of changes in clinical practice designed to drive meaningful clinical improvements over a shorter period of time. In the literature, colon bundles in particular have been shown to reduce superficial surgical site infections. However, bundle implementation can be a challenge, and expected rates of bundle adoption in multi-center initiatives are not well described. QI projects can require extensive resources, and data acquisition is often a barrier. Leveraging the NISQIP platform that is already collecting much of the needed data has potential to improve the ease of QI projects, especially over multi-center collaboratives. We aim to analyze colon bundle checklist compliance in a multi-center surgical quality initiative and identify checklist item-specific compliance rates. Our study was conducted through the Pediatric Surgery Quality Collaborative, which includes 27 participating children's hospitals. We developed an evidence-based 7-item colon bundle checklist and created custom variables through the NISQIP platform for each of the checklist items to track compliance and outcomes. We then compared colon bundle checklist compliance between control cases and colon bundle cases. Patients aged less than 18 years who underwent a colorectal operation with an anastomosis and abdominal closure were included in our study. The study took place over the time period of January 2023 and September 2024. The colon bundle checklist consisted of preoperative, intraoperative, and postoperative elements that are included here. Preoperative umbilical cleansing, preoperative antibiotic administration within 1 hour of incision as indicated, intraoperative anastomotic leak testing, maintenance of normothermia, use of a dedicated closure tray, glove change prior to closure, and postoperative discontinuation of antibiotics after 24 hours unless otherwise indicated. A total of 361 cases met inclusion criteria, with about 62% abstracted as control cases and 38% abstracted as colon bundle cases. We did not find significant differences in demographics between the two groups, except in race distribution. The median age of the overall cohort was 32 months, and mean BMI was 18. There were slightly more males in the cohort as well. Approximately 10% of all cases were classified as emergent in acuity, and about 2/3 of the cases were performed open, with a median operative time of 139 minutes. The most common anastomosis performed was small bowel to either colon or rectum at 41%. We awarded each case a bundle compliance score, which was calculated by awarding 1 point for each colon bundle checklist item completed. Colon bundle cases had significantly higher mean bundle compliance score compared to control cases, with a mean of 4.86 out of 7. Once centers adopted the colon bundle checklist, they had significantly higher compliance in the elements shaded here. 2 exceptions were preoperative antibiotic administration, which already had high compliance to begin with, and maintenance of normothermia, which showed no difference between the two groups. We then looked at trends of colon bundle checklist use over time. Here you can see the increase in colon bundle use across hospital quarters from Q1 in 2023 to Q3 in 2024. In comparing colon bundle checklist use for 2023 to 2024, we found that frequency of colon bundle use increased, rising from a rate of 20% in 2023 to over half in 2024. Additionally, the frequency of highly compliant cases, meaning a bundle score of 5 or more, increased from 37% to 67% from 2023 to 2024. We did not find any statistically significant differences in postoperative outcomes. However, this is a pilot study, and we are not yet at a large enough sampling of cases to reach statistical significance when looking at these specific endpoints. Our study did have some limitations, one of which being that we were reliant on documentation to determine colon bundle checklist compliance. However, we did make a huge effort to train surgical
clinical reviewers, and surgeon champions through monthly meetings to improve surgeon participation. Another inherent limitation with using the NSQIP-P platform is that it is a sampling of cases rather than all cases performed during that time period. Overall, we present the largest multi-center initiative using the NSQIP-P platform to assess the utilization of colon bundle checklists for pediatric colorectal surgeries. Benefits of the NSQIP-P platform to conduct QI projects are the customizable variables and less data entry required due to leveraging of already existing data collection. Significant compliance improvement, albeit imperfect, over 21 months reflects a realistic adoption rate of a multi-center initiative using the NSQIP-P platform. Future directions of our study include identifying successful implementation strategies at sites that are high performing, as well as exploring site-specific engagement methods. We believe that ongoing data collection with a larger data set and continued compliance improvement may eventually lead to statistically significant improvements in clinical outcomes. Thank you for your attention. I'm happy to take any questions.
We do have time for questions if there's anyone from the audience. While people are coming to the mic, I just quickly wanted to ask, what did you find were the barriers to implementation of the bundles?
Yeah, so one of the barriers to implementation of the bundles was how to implement the bundle. So we gave sites options of how they were going to implement it at their specific site. And I think the checklist had the lowest compliance when we used just a paper checklist. But once we implemented a dot phrase in the operative note where surgeons could easily check what components they were using, we found improvement in compliance and I think helped with one of the barriers to improving our implementation and compliance.
Great. Thank you very much.
Thank you.
The next presentation is pleural drain placement following resection of lung surgery in children, a prospective observational study of the Western Pediatric Surgery Research Consortium presented by Dr. Khan, who's a research fellow at Utah.
Perfect. Good morning, and thank you so much for the opportunity to present. So there are approximately 5,000 pediatric lung resections that are performed annually in the United States. While adult thoracic surgeons have really moved away from routine pleural drain placement following lung resection, pediatric surgeons have not yet adopted this less is more approach when it comes to pleural drains. In trying to better understand current practice, in 2024, our consortium conducted a survey of over 100 pediatric surgeons. And when asked about their pleural drain practices, 80% of surgeons who graduated fellowship more than 10 years ago said that they routinely place drains. This is in contrast to more recently graduated surgeons, where only 50% said that they routinely leave a drain. When asked about tolerance for unplanned chest tube placement, the average answer was a 6% rate of tolerance. So as a consortium, the next step was to build on this prior work and evaluate what surgeons were actually doing in practice. For this study, we had 3 aims. Firstly, to evaluate the safety of pleural drain emission after lung resection. Second, to assess the utility of intraoperative air leak testing. And third, to provide a contemporary characterization of pleural drain placement and management. We implemented a 10-hospital prospective observational study from 2023 to 2024. We included all patients less than 18 years old who were undergoing a thoracoscopic or open lung resection, and you can see the exclusion criteria listed here as well. The primary outcome of interest was unanticipated pleural drain reinsertion, and secondary outcomes were the results from intraoperative air leak testing, pleural drain management, x-rays, and length of stay. So overall, we included 229 patients in our observational cohort, the majority of whom were male, and 57% were under 1 year old. The most common indication for operation was for CPAM or BPS. There was nearly an even split between the wedges and lobes, and the majority of patients had their procedures performed thoracoscopically. Over 86% of the cohort had an air leak test performed, 15% had a positive air leak test, and over 84% of patients had a negative intraoperative air leak test. In looking at our pleural drain placement patterns, we found that over 87% of patients received a pleural drain. There was a statistically significant difference between the wedges and lobes, and all patients with a positive intraoperative air leak test received a drain. However, 85.7% of patients with a negative intraoperative air leak test still received a drain. And lastly, 62% of drains that were placed were rigid straight drains, and this was higher than we expected given evidence that soft drains are equally as effective but less painful. When looking at patients who did not leave the operating room with a drain, there were no patients in this group that required a drain postoperatively, meaning for our primary outcome, there was 0% postoperative insertion rate in the non-pleural drain group. We then looked at air leak testing, and you can see here a significant difference between both the pleural drainage days and air leak days in these cohorts. So for patients who had a negative intraoperative air leak test and still received a drain, they had a median of only 1 day of drainage before that drain was removed, and 0 air leak days postoperatively. The majority of patients had their drains removed on water seal, and there was no difference between the negative and positive tests. Looking at pleural drain management, you can see there was no significance between wedges and lobes in terms of the median pleural drainage days or the air leak days. However, there was a significantly higher number of lobes who had their drains removed on water seal, which was also surprising, given that we know that removing tubes on suctions can be safe. Comparing the pleural drain and non-pleural drain groups, there was a significant difference in postoperative chest x-rays. So pleural drain patients received almost 2.5 times number of chest x-rays as the no drain group. And the median post-op length of stay was 2 days longer for the drained patients. Of the patients who did leave the operating room with a drain initially, there were 5 patients who required reinsertion after the drain was removed, and notably, none of these patients had a reinsertion for a pneumothorax. So in summary, we found that over 85% of patients who received a pleural drain did so despite having a negative intraoperative air leak test. For those patients that had a negative intraoperative air leak test and still received a drain, they had only 1 day of pleural drainage and no air leak days. There were no patients who required a postoperative insertion of a pleural drain who did not receive one after the OR. And chest x-ray utilization and thus radiation exposure was nearly 3 times higher in the patients with drains. In conclusion, our evidence would suggest that pleural drainage in pediatric patients is not always necessary after lung resection, and a negative intraoperative air leak test may be an indicator that a tube is not necessary. I would like to thank all of the principal investigators and research coordinators throughout the WIPSERC who made this work possible, as well as the project lead and my mentor, Dr. David Rothstein at Seattle Children's. I'll take any questions. Thank you so much.
I have a question. So based on this data, have you already transitioned to a prospective no pleural drain placement and see how many times were you wrong?
Currently, we're looking at doing a randomized control trial looking exactly at that. Given that this was observational, we didn't ask anyone to change their current practices. So across the WIPSERC, I'm not sure if anyone has adopted it, but we'll have to see what comes from this data.
Thank you.
The next presentation is pleural drain placement following resectional lung surgery in children, a prospective observational study of the Western Pediatric Surgery Research Consortium presented by Dr. Khan, who's a research fellow at Utah.
Perfect. Good morning, and thank you so much for the opportunity to present. So there are approximately 5,000 pediatric lung resections that are performed annually in the United States. While adult thoracic surgeons have really moved away from routine pleural drain placement following lung resection, pediatric surgeons have not yet adopted this less is more approach when it comes to pleural drains. In trying to better understand current practice, in 2024, our consortium conducted a survey of over 100 pediatric surgeons. And when asked about their pleural drain practices, 80% of surgeons who graduated fellowship more than 10 years ago said that they routinely place drains. This is in contrast to more recently graduated surgeons, where only 50% said that they routinely leave a drain. When asked about tolerance for unplanned chest tube placement, the average answer was a 6% rate of tolerance. So as a consortium, the next step was to build on this prior work and evaluate what surgeons were actually doing in practice. For this study, we had 3 aims. Firstly, to evaluate the safety of pleural drain emission after lung resection. Second, to assess the utility of intraoperative air leak testing. And third, to provide a contemporary characterization of pleural drain placement and management. We implemented a 10-hospital prospective observational study from 2023 to 2024. We included all patients less than 18 years old who were undergoing a thoracoscopic or open lung resection, and you can see the exclusion criteria listed here as well. The primary outcome of interest was unanticipated pleural drain reinsertion, and secondary outcomes were the results from intraoperative air leak testing, pleural drain management, x-rays, and length of stay. So overall, we included 229 patients in our observational cohort, the majority of whom were male, and 57% were under 1 year old. The most common indication for operation was for CPAM or BPS. There was nearly an even split between the wedges and lobes, and the majority of patients had their procedures performed thoracoscopically. Over 86% of the cohort had an air leak test performed, 15% had a positive air leak test, and over 84% of patients had a negative intraoperative air leak test. In looking at our pleural drain placement patterns, we found that over 87% of patients received a pleural drain. There was a statistically significant difference between the wedges and lobes, and all patients with a positive intraoperative air leak test received a drain. However, 85.7% of patients with a negative intraoperative air leak test still received a drain. And lastly, 62% of drains that were placed were rigid straight drains, and this was higher than we expected given evidence that soft drains are equally as effective but less painful. When looking at patients who did not leave the operating room with a drain, there were no patients in this group that required a drain postoperatively, meaning for our primary outcome, there was 0% postoperative insertion rate in the non-pleural drain group. We then looked at air leak testing, and you can see here a significant difference between both the pleural drainage days and air leak days in these cohorts. So for patients who had a negative intraoperative air leak test and still received a drain, they had a median of only 1 day of drainage before that drain was removed, and 0 air leak days postoperatively. The majority of patients had their drains removed on water seal, and there was no difference between the negative and positive tests. Looking at pleural drain management, you can see there was no significance between wedges and lobes in terms of the median pleural drainage days or the air leak days. However, there was a significantly higher number of lobes who had their drains removed on water seal, which was also surprising, given that we know that removing tubes on suctions can be safe. Comparing the pleural drain and non-pleural drain groups, there was a significant difference in postoperative chest x-rays. So pleural drain patients received almost 2.5 times number of chest x-rays as the no drain group. And the median post-op length of stay was 2 days longer for the drained patients. Of the patients who did leave the operating room with a drain initially, there were 5 patients who required reinsertion after the drain was removed, and notably, none of these patients had a reinsertion for a pneumothorax. So in summary, we found that over 85% of patients who received a pleural drain did so despite having a negative intraoperative air leak test. For those patients that had a negative intraoperative air leak test and still received a drain, they had only 1 day of pleural drainage and no air leak days. There were no patients who required a postoperative insertion of a pleural drain who did not receive one after the OR. And chest x-ray utilization and thus radiation exposure was nearly 3 times higher in the patients with drains. In conclusion, our evidence would suggest that pleural drainage in pediatric patients is not always necessary after lung resection, and a negative intraoperative air leak test may be an indicator that a tube is not necessary. I would like to thank all of the principal investigators and research coordinators throughout the WIPSERC who made this work possible, as well as the project lead and my mentor, Dr. David Rothstein at Seattle Children's. I'll take any questions. Thank you so much.
I have a question. So based on this data, have you already transitioned to a prospective no pleural drain placement and see how many times were you wrong?
Currently, we're looking at doing a randomized control trial looking exactly at that. Given that this was observational, we didn't ask anyone to change their current practices. So across the WIPSERC, I'm not sure if anyone has adopted it, but we'll have to see what comes from this data.
Thank you. And Dr. Kahan will remain up on the podium for the next presentation, which is entitled Small Change, Big Impact, Proposal of the Brain Injury Guidelines for Kids, K-BIG.
Okay, thank you again for the opportunity to present. We're going to change gears a little bit. Okay, so for those in the audience who don't take care of adult patients, so everyone, the standard of care for triaging adult traumatic brain injuries is to apply the Brain Injury Guidelines, or BIG. These are based on the patient's initial presentation and head CT findings highlighted here. So these guidelines triage patients into 3 categories. The lowest risk is Big 1, and these patients are managed with observation alone. Big 2 or moderate risk patients are admitted under the care of trauma surgeons, and Big 3 or high risk patients are admitted with repeat imaging and neurosurgical consultation. So these adult guidelines have been validated many times across large studies and across different centers. And in single center retrospective studies, the adult guidelines have also been shown to be safe in children. However, we know that children have unique injury patterns compared to adults, so we felt left to answer the question, is BIG the best that we can do in kids? For our study, we wanted to first determine the efficacy of BIG in pediatric trauma patients, and secondarily, to see if the adult guidelines could be better adapted to fit injury patterns that are unique to children with TBI. We performed a trauma registry poll of all pediatric blunt patients seen from 2018 to 2024 at our center who had a TBI with or without an intracranial hemorrhage. And we then performed a thorough chart review of each patient. Matching the adult studies, we used a primary outcome of neurosurgical intervention in the low and moderate risk patients, so Big 1 and 2 patients, indicating that they were misclassified by the adult guideline. And the secondary outcomes we also looked at are listed here. We had 1,894 patients in our cohort, 439 of whom were isolated skull fractures who don't fit into the adult BIG. So we included these in a sub-analysis, which I'll talk about momentarily. The majority of our patients were male, Caucasian, and non-Hispanic, with a median age of 5.5 years old. The most common injury mechanism was fall. So first we applied the adult BIG to our pediatric cohort. As expected, it missed 0 of the patients in the lowest risk group. However, the adult guidelines missed 8 moderate risk patients who required operative intervention, giving us a misclassification rate of 1.4%. We then looked at injury patterns that we saw in our cohort, and we found that 1/4 of all kids with an epidural hematoma, non-accidental trauma, and 40% of displaced skull fractures ended up in the operating room. This indicated to us that there are unique injuries in children that need to be explicitly categorized by a guideline. So taking these results, and in collaboration with our neurosurgical and radiology colleagues, we made modifications to these adult criterion to create our pediatric-specific TBI triage guidelines, BIG for kids, or KBIG. So we proposed 6 changes to the adult brain injury guidelines. These included the creation of a new category of minor isolated skull fracture in the neurologically normal patient. We downgraded minor skull fracture to the lowest risk group, and we upgraded epidural hematomas to at least the moderate risk group. We upgraded all suspected or confirmed child abuse to the highest risk group. We redefined normal as only a GCS of 15 for KBIG 0s and 1s, and we eliminated the observation period for the lowest risk patients. So here are the modified triage guidelines, BIG for kids, or KBIG. And as you can see, we have a new group, KBIG 0. This is the isolated skull fracture patients. And this better captures this unique injury pattern that we see in children and increases the applicability of our guidelines, and it did so for us almost by 30%. Similar to the adult guidelines, if a patient fits into the lowest risk category, KBIG 0 or 1, the recommendation is that they're discharged home. Moderate risk patients are recommended to be admitted under the care of trauma surgeons, and only the high risk patients are recommended to have repeat imaging and neurosurgical involvement straight away. We then reapplied KBIG to our population to see how it stacked up against the adult guideline. We found that similarly, we missed 0 of the lowest risk patients, and we were able to improve this misclassification rate from 1.4% to 0.8%. Lastly, we performed a resource utilization analysis to see what KBIG theoretically could have done to optimize hospital resources had we been using this to triage and treat our TBIs. We found that if KBIG had been in place, we would have had a 36% reduction in repeat head CTs, a 52% reduction in neurosurgical consults, a 36% reduction in TBI admissions for isolated TBI, and a 26% reduction in isolated TBI transfers at our institution. There are inherent limitations to retrospective reviews, and KBIG does not capture these CT imaging findings that might have been seen. And the next steps of our research include retrospective validation across 10 children's hospitals through the WIPSRC. Additionally, we're performing a prospective implementation of KBIG across the UPTN through the state of Utah. In conclusion, we found that the adult guidelines do not account for unique injury patterns in children with TBI. Our modifications safely account for these patterns while identifying the patients who are most likely to need the neurosurgical interventions. I'd like to thank everyone in the Mountain Research Lab who conducted this work, including my PI and mentor, Dr. Katie Russell. Thank you so much.
Are there any questions from the audience for this study? Well, this is a really great work. Could you just talk a little bit more about the next steps and the future directions for the upcoming studies?
Yeah, absolutely. So we're performing a validation now for the KBIG itself across 10 children's hospitals, like I said. And our plan is to validate all of the findings that we had specifically at Utah. Additionally, looking at some of those CT imaging findings that weren't captured initially, like pneumocephalus. And then for future work, we're doing a quality improvement project through the UPTN, where we've implemented KBIG as of January and doing weekly and monthly PDSAs to make sure that it's continuing to be safe. And so far it has.
Thank you very much.
Thank you.
And our final talk is not like our neighbor. Excuse me, cross-national comparison of pediatric firearm injury in the US and Canada, presented by Dr. Dempsey, general surgery resident, Texas Medical Branch.
Good morning, everybody. Thank you for the introduction, and thank you for the opportunity to share our work with you today that we carried out in conjunction with the Advocacy Committee's Gun Violence Subcommittee. The authors have no disclosures for this talk. Now, I'm sure many of us are readily aware of the growing public health crisis that is firearm trauma, with the US population specifically seeing that this is now the leading cause of mortality in our pediatric age groups, having surpassed motor vehicle accidents as of 2020. And in fact, the United States is the only high-income country where this is the case, with all peer countries reporting cancers and motor vehicle accidents as the leading causes of mortality. Even here in Canada, our closest neighbors, we see that firearm mortality ranks 5th as leading causes of death for this age group. Though it's important to note that both of these countries have high gun ownership, with US ranking 1st and Canada 5th on a global scale for civilian firearm ownership. So with these countries being in a similar geographic region, having a lot of access to these firearms, and having similar socioeconomic and cultural norm populations, why is this burden so much more in the US? This led us to want to compare the incidence, mortality, and etiology of these pediatric firearm injuries, comparing the populations of Canada and the United States between 2017 and 2021, with the hopes of identifying disparities in those that are affected to highlight potential targets for preventative measures. To do this, we utilized the Global Burden of Disease database, which we queried for all pediatric patients, which included ages 19 years and younger, that had suffered from firearm injury in these two countries over the 5-year study period. We standardized the incidence, mortality, and overall mortality rate for both of these countries based on relative population size using annual mid-year census data. And we stratified our data by age, sex, and etiology of the injuries to compare between the two countries. Now, looking at our overall data, we see that the majority of injuries, specifically 95%, are from the US population, with the fatal injuries, 99% of those being in the US population as well. And from these injuries, we see a mortality rate of almost 10% compared to only 2.6% in the Canadian population. And looking at the annual rates, standardized for population size, we see a 1.5 times higher incidence and 5.8 times higher mortality in the US population. Now, when we look at etiology of these injuries, on the right, represented in gray, we see that Canada has a vast majority of these injuries being attributed to unintentional or accidental causes. Meanwhile, the United States, almost 50% are due to physical violence or intentionally inflicted injuries. And taking a step back at our overall trends in the incidents, we found that the United States had stable incidents over this study period, whereas Canada, the incidence was decreasing. And luckily, mortality decreased, albeit slightly, for both of these countries. Now, when we divide this data out by age groups, we see, with the incidence represented here in yellow, that Canada has a slightly increasing incidence as we go up into the older age groups, with the biggest spike being in the 15 to 19 age group. However, we see that this is much more dramatic in the US population, with mortality represented in red following suit, with a slight increase in Canada and a large jump in the US population for this older age group. Dividing out by etiology, we see that for all age groups, Canada still had unintentional causes as the prevalent etiology. Whereas in the United States, we can attribute a lot of this spike in our older population due to physical violence, intentionally inflicted injuries. Though important to note that the next highest group that this occurs in is in our younger age group that are less than 5. And dividing out by sex, we do see a male predominance among both populations. However, the proportional etiologies and how they're affected between male and female on the Canada side remain pretty consistent. Meanwhile, on the United States side, we do see a higher prevalence among both sexes of physical violence injuries, though this is much more drastic among the males. So that was a lot of data. So to summarize quickly, the US has an overall 1.5 times higher incidence and 5.8 times higher mortality due to firearm injuries in the pediatric population. And most of these injuries in Canada are due to unintentional shootings rather than physical violence, which is more prevalent in the US. And while incidence has been stable in the US, it is declining in Canada, and males are disproportionately affected among both. So, why are these differences here? We propose that a lot of this has to do with policy, with Canadian legislature being handled at the federal level and universally applying across the country. And this involves extended background checks and training that is required for all firearm owners, which is not consistently applied in the US. There's also stand your ground laws in the US allowing civilians to use lethal force against perceived threats. That's not allowed here in Canada. There's also much more bans on the types of firearms that can be owned as far as higher powered weapons, bigger magazines, more destructive bullets, all being outlawed here, as well as limitations on the quantity any person can own, which there are much fewer of those restrictions in the US. So while the pediatric population in the US faces a significantly higher burden of firearm injury, both the incidence and mortality, than in Canada, we propose that working to align our firearm policy in the US to more closely align with those that are seen here in Canada has the potential to greatly reduce the burden of these injuries and save some of our kids. Thank you so much. I'll be happy to take questions.
Congrats on a terrific subject and an important one, nicely presented. My question is, I wonder if you looked at access and social determinants, because it's the changes are so dramatic.
Mm-hmm.
Is it mostly access, or do you think there is also a difference in the Childhood Opportunity Index or the SVIs in these patients?
So with this database, we didn't have data to assess at that granular of a level. Looking into a lot of the differences, I do think that there is a big difference just based on the type of weapons and how readily available they are. Because while Canada is a high gun ownership country, there's about 1 firearm for every 3 residents, whereas in the US there's actually more firearms than there are residents. So there's more available, a lot more higher powered weapons, more destructive bullets. All of these things really increase the mortality. And then there's just a lot that goes into the historical landscape of people needing their guns for protection in the US that hasn't been a prevalent feeling here in Canada.
Thank you.
Thank you.